everybody. How you doing this evening? It's actually spring. Welcome to our event tonight. My name is Brenda Moynihan, and I am the Director of Marketing and Outreach here at the Kensington Assisted Living Residence. And tonight's presentation is the warning signs of sudden weight loss in older adults. And during the presentation tonight, we're going to learn about the causes, strategies, and some tips on how to mitigate weight loss in older adults. And before I introduce our speakers, I'd like to briefly give you some information about the Kensington. For those of you that don't know about us, we are actually an enhanced assisted living. We're located in White Plains, and our specialty is folks who are physically and or cognitively frail. So if you know of anyone, please feel free to call us 914-390-0080, or you can always go to our website at www.thekensingtonwhiteplains.com. And with further ado, let me introduce our speakers and welcome them this evening. Our first is Laura Cardella. She is a senior clinical dietitian at York-Presbyterian Westchester Behavioral Health Center. Laura specializes in treating eating disorders and disordered eating patterns in the inpatient, partial hospital, and outpatient level. Received her Bachelor of Arts in Psychology from Loyola University in Maryland and completed a Master of Science in Nutrition at SUNY School of Public Health at Hunter College. After completing her dietetic internship at New York Pres, Laura went on to complete a 6-month fellowship specializing in treating eating disorders. Laura was recognized as Registered Dietitian of the Year in 2020 and Dietetics Preceptor of the Year in 2021. Laura is passionate about helping people improve their relationships with food and the complex connection between nutrition and mental health. Thank you and welcome, Laura. Our second presenter for this evening is Laurel Gumpert. Laurel is the Educational Program Coordinator at the Alzheimer's Foundation of America. Laurel graduated from Stony Brook University with her Master's in Public Health and Master's in Business Administration with a concentration in Community Health in 2020. Laurel is part of the Delta Omega Public Health Honorary Society Lambda chapter. She served as an ambassador for the Association of Schools and Programs of Public Health to encourage individuals to pursue careers in the field of public health and healthcare. Laurel has experience in qualitative research and in clinical trials and is thrilled to use her previous knowledge to create meaningful educational opportunities at the Alzheimer's Foundation of America. Laurel is certified as a health education specialist from the National Commission for Health Education Credentialing. Welcome, Laurel. And Laurel will be our first speaker for this evening. Welcome, Laurel, and it's all you, girl.
Well, thank you so much, Brenda. I appreciate your warm welcome as always. And I'm just going to share my screen. All right, wonderful. Well, thank you all so much for joining us this evening. Like Brenda mentioned, my name is Laurel Gumpert, and I'm the Educational Program Coordinator at the Alzheimer's Foundation of America. And I'm very happy to be speaking with you all today. We're going to be talking about eating as we age. And specifically, I'm going to be talking about dementia, Alzheimer's disease, and how we can best create healthy meal times for this population. So first off, thank you again to our wonderful friends at the Kensington, especially Brenda Moynihan. Thank you again so much for having us. So with that, let's get started. Let's dive in. So first off, what is dementia? Broadly, dementia is a general term of decline in mental ability that interferes with daily life. Dementia is not a disease, but rather it's an umbrella term with diseases underneath. So we see vascular dementia, we see frontotemporal dementia, and most well known, we have Alzheimer's disease. And most types of dementia cause a gradual worsening of symptoms, as dementia is a neurodegenerative disease. We see that dementia impacts many areas, including memory, judgment, motor skills, communication, and mood. And the impact of dementia is quite widespread, and it is based on the type of dementia the person has. So I mentioned Alzheimer's disease. Alzheimer's disease is the most common type of dementia, as it contributes to approximately 60 to 70% of all dementia cases. And Alzheimer's disease is a dementia that impacts memory, thinking, language skills, and the ability to carry out the simplest of tasks. And Alzheimer's disease is due to atrophy or shrinking of cells in the brain that cause brain cells to inevitably die. So let's look at the stages of Alzheimer's disease. There are three main stages of Alzheimer's disease. So we're going to start first off with early stage. In the early stage, we see problems with complex mental tasks. We see confusion or disorientation in familiar places. I was just sharing before we started that I have started working in the city for about 10 months now, and I'm really getting used to the blocks and the avenues. And I'm starting to get really familiar that if you were to drop me off by my office, I'd be able to pretty easily navigate where I was going. However, for other individuals, this may never be something that they're comfortable with. So really understanding people's familiarity in these situations and seeing these differences in familiar places, familiar people. We also see difficulty learning new tasks or remembering new people. And individuals may feel overwhelmed by excessive stimuli or multiple choices. So I want you all to keep that in mind. We're going to talk more about this in a little bit, but just thinking about how we can keep meal times and the routines around eating a little bit. We want to keep it simple. In the middle stage of Alzheimer's disease, this is typically the longest stage, and we can see disturbances in the sleep-wake cycle. We also see hallucinations, which is when we may see, smell, taste, or feel things that are not actually there, as well as delusions, which are fixed false beliefs. We also see that individuals have difficulty executing personal care independently, which can include eating, drinking, and using utensils. And verbal communication can become increasingly difficult in this stage. So for example, if someone is hungry, they may use behaviors if they are hungry. So we may see increased agitation or wandering behaviors as means to communicate their needs that they are hungry. And then we have late stage. And this looks at, we see severe language and motor impairment. And the individual does require complete assistance with personal care. That includes eating, drinking, and swallowing, as well as general widespread disconnect from the environment, people, and oneself. So changes in eating can really begin at the early stages, but as the disease progresses, we continue to see greater difficulty in eating, and the types of symptoms that we see change as well around eating. So what does Alzheimer's disease do to the brain? We can see kind of these changes in symptomology as we go throughout the stages. But what does this actually do to the brain? Well, in Alzheimer's disease, we have neurons. These are our nerve cells, and they get injured and die throughout the brain. That means that the connections between the network of neurons, they may begin to break down, and then many brain regions begin to shrink. So in the final stages of Alzheimer's disease, we see brain atrophy, which is where we see loss of significant brain volume. So we're talking about Alzheimer's disease. We're talking about these changes in the brain. How do these changes impact eating? Regular nutritious meals may become a challenge for people living with Alzheimer's disease. They may feel overwhelmed, as I mentioned, with early stage. They may have too many choices and it may be too difficult to figure out what to eat. The dining room table may be too overwhelming or distracting. And then as we begin to move on to the middle and later stages, individuals may forget to eat um, or think that they have already. So it is important to ensure healthy eating habits across all stages of Alzheimer's disease and pay attention to eating habits, changes in flavor and taste buds, engaging all the five senses in our meal times, and ensuring that our care partners exercise patience during eating. So let's look briefly at taste buds. People with dementia may not experience flavor the same way they once did. We see that people with dementia have trouble identifying flavors and may lose the ability to remember taste. And at the same time, taste diminishes as we age, which can lead to increased cravings of sweet or heavily flavored foods. Also, in general, taste buds change over time. So what may have tasted great for a person one day may not taste so good the next day. So we want to pay attention to these changes with the progression of disease and understand that if someone no longer likes something, that is okay, and that we can be as adaptable as we can with the changes that come with dementia. So with Alzheimer's disease, what are some causes of poor appetite? Why do we see changes in eating? So someone may not recognize food. They may not understand that what in front of them is food, that it is edible, or individuals may actually try and eat things that are inedible, for example, like a candle. Another cause may be poor fitting dentures. This may cause pain while eating, some discomfort that they'd rather just not eat because of the pain that they're feeling. We also can see this with medication. This can cause changes in appetite, making someone more or less hungry. So if someone just starts medication and we see it rapidly changing their eating habits, this may be something you want to talk to with your care team to see if you can find a medication that may be better suited. There's also not enough exercise or stimulation, and this may not be applicable to everyone. This is not me saying we all have to go outside and run a 5K this moment, but for some people, this does mean that going out and having more stimulation can increase that appetite as well. And as I mentioned, there's a decreased sense of taste and smell. Alzheimer's disease can significantly diminish sense of smell, and that may make food not taste good. In Alzheimer's disease, we see the protein beta amyloid. It clumps in individuals' brains, and research has shown that there's a significant association between beta amyloid and loss of smell. So it does make sense that with individuals with Alzheimer's disease, that sense of smell really does change over time. So we're looking at those five senses and at taste buds to try and make meals as engaging and comfortable for our individual. So now that we see these changes in the brain and how it can impact eating habits, what are ways that we can assist? How can we make meal times more comfortable and encourage healthy eating habits? So first, we're going to want to limit distractions. We're not going to want TV playing in the background or texting on the phone. We want to focus on mindful eating. So mindful eating means being fully attentive to your food as you consume it. We want to pay attention to hunger and fullness cues and really be engaged in the food that we're eating. If you're having a chip, putting it in your mouth and seeing how it tastes, how it feels, and paying attention to that in that moment. So we really like mindful eating, and that research has shown it's very healthy, as well as, there's more and more research on intuitive eating as well. So we do want to limit that to those distractions. So we're focusing on the food, focusing on it at hand. We also want to check food temperature. Make sure food isn't too cold or too hot. And we also want to offer one item at a time. Again, we're limiting those distractions to keep it a calm environment. We're not making it overwhelming. Again, we're thinking of those early stages. We want to focus on not overstimulating. We also, in the same line, we want to not ask open-ended questions like, do you want to eat right now? Around food and these different choices, we want to give the individual options. So rather than saying, again, do you want to eat? When it's about time for dinner, we can just say, would you like chicken or salmon? These are the options. We also want to encourage independence, which I think is so valuable. If the individual can eat with their hands and not with a fork, I encourage you to let them eat with their hands. If they can use a napkin, let them use it in the way that they can. We want to keep the individual as independent as possible while also keeping them safe. But still remembering throughout this that these individuals are accomplished adults, and we want to see them this way throughout the Alzheimer's disease progression. We also want to keep the table simple. I am known to be a bit of an over decorator, but in these cases, we may want to remove that beautiful vase of flowers or not over decorate the table, because again, we're paying attention to mindful eating. Our goal, and we say this a lot at AFA, is to keep things simple. We want to create interventions that make your life easier. And sometimes that really just means removing some of the things that can take our mind off of what we're really focused on. And we also recommend a plate lift. So something that you can put the plate on that makes it closer to the mouth so it's easier as you're eating, as well as perhaps weighted utensils. This gives the utensils a little more substance in their hands and makes it easier, for example, for individuals who may experience tremors. And this is quite common for people with dementia. So how can we ensure that the person eats well? Laura's going to get a little more into it, but for an individual with dementia, one idea is to serve a bigger portion at breakfast as it is the first meal of the day. This can really set them up for success and allow them feeling full and some more energy in the morning. We also suggest offering several smaller meals throughout the day so as to not necessarily focus on those 3 main meals that can be very heavy or could lead to that like 3 p.m. grogginess in between lunch and dinner when you have no energy. Maybe that's just me, but I know someone else definitely feels that way too. And also having several meals throughout the day keeps those nutrients coming into the body. We also want to serve meals at the same time every day. With dementia, we love routines and encourage healthy habits. They can be very helpful. And we also want to make eating a calm, quiet area. Again, we're trying to stay mindful by keeping meal times relaxing. One way we want to do this is by giving ample time to eat. We don't want to rush. And perhaps playing some relaxing music to set the mood. So moving on from eating, but very related, I want to talk briefly about dysphagia. So dysphagia is really just a fancy word for difficulty swallowing, which is very common for individuals in late stage Alzheimer's disease. And this happens when an individual's esophagus no longer functions properly. And we see this with people with dementia because dementia affects nerves, and these nerves are in control of our muscles and some of the muscles involved in the very vital process of swallowing. So what are some common signs of dysphagia, things that you may want to look out for? We see additional time and effort spent at meals, food, liquid, or saliva leaking out of the mouth, cheeking food, which is when we're keeping food in our cheek instead of swallowing them. gurgling sounds or a gurgling voice after meals, frequent coughing, gagging, or choking while eating. And we see weight loss, dehydration, and chest congestion. So with dysphagia, as we move throughout the stages of Alzheimer's disease, our goal is to keep mealtimes safe. So what are some treatments for dysphagia? First, we can look at a speech language pathologist. Speech language pathology is very important, and I've noticed that it can be very underutilized for individuals with dementia, but they can conduct something called a swallow study. And this is one way to assess dysphagia and swallowing capabilities. We also recommend getting a checkup with the dentist, kind of like a process elimination to make sure that teeth and dentures are not getting in the way and making swallowing more difficult. And we also recommend speaking with a registered dietitian or a nutritionist who can help create a diet that is focused on dysphagia and help you find foods that are more comfortable for an individual with dysphagia, and having that tailored approach for individuals with late stage Alzheimer's disease. So what can we do? We want, well, one thing is that we want people to be open with their physicians, with their care team, to help create an individualized plan that works for you. This involves being transparent about our symptoms to create this plan that is best. What works for me may not work for Brenda or Laura, and that is okay. That is what we want to write down notes about how this person may be feeling. And remember that nothing is ever not worth sharing, and that transparency can be really important. We also want to create a meaningful and engaging environment for mealtimes. Mealtimes in general are times to be spent with family, catching up. And for me, and I'm sure so many of you, that there are so many beautiful memories that you may have with family and friends around the dinner table. And even though with Alzheimer's disease, there are so many changes, mealtimes can still be meaningful. They're just going to look different than they were before, and that's okay. We also want to be adaptable with meals, understanding that Alzheimer's disease will change aspects. They're going to change eating and eating behaviors. But since the disease is neurodegenerative, it can change from day to day. So we want to be willing to try something out at mealtime. And if it doesn't work, that's fine. Then we try something else out. Adaptability and flexibility are incredibly important. And we encourage help, like I said, from speech language pathologists, dentists, registered dietitians, geriatric care managers. There's so much that goes into healthy eating. When I was making this presentation, I felt like I could have talked for so long because there is so much that goes into this. So having a group of experts that can advocate for you is highly valuable. And this is why you all will have the pleasure to hear from Laura next, as she is a registered dietitian. So you'll be learning more about the value that a registered dietitian can bring to your care team. But getting as many opinions as possible and learning from different people can really help with eating changes in Alzheimer's disease and address some of these misconceptions that we may see as well. And lastly, I encourage you to take it one step at a time, one day at a time. At AFA, we have a helpline that's open 12 hours a day, 7 days a week. Brenda will have my information, that is staffed with all licensed social workers willing to help anyone who calls. No problem is too big or too small for us. And we understand that these changes can be immensely difficult, but I guarantee you that AFA will be there for you every step along the way and helping you just take it one step at a time. So thank you all so much. With that, I'd like to pass it on to Laura Cardella.
I'm sorry, I can't seem to get my video started.
Hi, everyone, and thank you so much for having me this evening. I'm going to go ahead and share my screen. So to get us started this evening, I'd like to share some statistics. So we're bombarded with messages about the health benefits of weight loss and the consequences of being too high in weight. We're always hearing about new diets to promote weight loss. Even in medical settings, the consequences of being overweight or obese are highlighted, while the consequences of weight loss or being undernourished are often ignored. So today, what I would like to share with you all and highlight is the causes, the risks, and some possible interventions for weight loss among the older adult population. So up to 71% of hospitalized older adults are malnourished or at risk, at high nutritional risk. So that's nearly 3/4 of adult patients, older adult patients we see in the hospital either have malnutrition or are at very high risk. Unintentional weight loss in older adults is associated with an increased risk of mortality. And weight loss among nursing home residents predicts increased mortality regardless of the underlying diagnosis. So these statistics really highlight why we need to start talking a little bit more about weight loss among the older adult population. So compared to younger adults, undernutrition in older adults is much more common and often has much greater health impact. So the National Institutes of Aging describes failure to thrive as a syndrome of weight loss, decreased appetite, and poor nutrition and inactivity, often accompanied by dehydration, depressive symptoms, impaired immune function, and low cholesterol. Many of the features of failure to thrive are actually defined as features of frailty, including weight loss, malnutrition, and inactivity. So what this is saying is weight loss, even intentional weight loss, so definitely unintentional weight loss, but even in a lot of cases, intentional weight loss can increase risk of this failure to thrive, this, increased risk for early mortality from certain diseases. When we're talking about weight loss and clinically significant weight loss, I want to make sure everyone's on the same page. As little as 5% weight loss over a period of 6 months to a year is considered significant and should be looked into further. And I will talk a little bit more about that in a bit. Now, oftentimes, when we hear about the dangers of weight loss, we think that this only applies to people who are underweight or at risk for becoming underweight. And this doesn't apply to someone who might be overweight or obese. So actually, these consequences don't just apply to people who are underweight. They apply to even people who are overweight or obese. Research actually suggests that having extra weight can be protective and not harmful in the older adult population. This is obviously very different from the recommendations among the younger adult population. And that is why oftentimes people don't recognize that recommending weight loss in someone who is overweight could actually have negative consequences in some cases. So unintentional weight loss was associated with a 24% relative increase in mortality during the follow-up period, even among those with obesity. Unintentional weight loss has been shown to have a negative effect on functional decline, regardless of BMI. And just so folks understand, BMI is height relative to weight. So when we think of a healthy BMI traditionally, we think of a BMI between 19 and 25 as healthy. In older adults, actually, there's research that suggests that the BMI range between 25 and 35 actually is a bit better and can be protective in some of the negative outcomes associated with aging. So older adults with a BMI of less than 25 or a BMI of greater than 35, so the two sort of extremes, were at higher risk of a decrease in functional capacity. So like I said, data suggests that the ideal weight range for longevity was actually in the overweight category, which tends to be really shocking to people because, you know, throughout our entire lives, we're you know, given the message that being lower in weight is better and weight loss is always recommended when you're overweight. In the older adult population, this is not the case. So why do we not want older adults to lose a significant amount of weight? These are the poor health outcomes associated with undernutrition and weight loss. Firstly, a decrease in functional capacity due to the natural loss of lean mass when you lose weight. Of course, an increased risk for fat fractures in someone who has weight loss or is considered low in weight. Gastrointestinal changes. So people often don't realize that undernutrition and weight loss in and of itself can actually lead to gastrointestinal changes. When we're not eating enough, when we're not getting enough nutrients and we lose weight, just like any other muscle in our body, the digestive tract and the organs associated with digestion atrophy. They become weaker when we're not providing the body with enough fuel. So it's very common for someone who has had significant weight loss, for someone who is consistently not eating well, to have nausea, to have vomiting, to have constipation or diarrhea. These symptoms are actually a result of the undernutrition and weight loss in a lot of cases, and not the cause. Oftentimes people are searching for the cause of GI symptoms that they're experiencing without realizing that actually the undernutrition and the weight loss came first and sort of worsens those GI changes over time. Of course, someone who loses weight is at higher risk for falling. Losing weight and eating less actually changes our hunger and fullness hormones. So when you're eating less over time as a way to sort of conserve energy, our body actually over time starts producing less hunger signals. So the less we eat, the less likely we are to feel hungry and this is of course over a long period of time. In the short term, of course, in a healthy, normal weight adult, we're going to feel hungry when we are hungry. But as someone loses weight and is chronically undernourished, those signals stop working in the same way. Fullness feelings also change when someone's not eating well. So someone who has lost weight, someone who has undernutrition, they're going to feel fuller than someone who doesn't, fuller sooner, and likely then still not be able to get the nutritional needs that they need. Weight loss is stressful to the body. It increases cortisol levels, which we know has an increase in cortisol levels are associated with all sorts of poor health outcomes. Eating too little also we see causes a preoccupation with food. So this is a confusing one for some people, because we might hear our patient or our loved one talking about food all the time, perseverating over different types of foods, thinking about foods, planning out meals. But then when it comes to the actual eating of food, has much difficulty. This can happen. So the increased thoughts about food actually are a biological survival mechanism when we're chronically not getting enough food. So you might hear your loved one or your patient talking a lot about food and thinking a lot about food, but that doesn't necessarily mean they're actually eating food. So it's important to really investigate that and know for sure that the person is eating well if they've had significant weight loss. We also see an increase in somatic preoccupation, so sort of a physical manifestation of anxiety we can see increase when someone's not eating well. We see a significant increase in anxiety and depression when someone loses weight and isn't eating well. So just like any other physiological health outcome associated associated with poor nutrition and weight loss, when the neurotransmitters in our brain, when the hormones that are involved in regulating our mood, controlling our anxiety, contributing to depression, all of these neurotransmitters are impacted by poor nutrition. So if those neurotransmitters are not getting enough nutrition, absolutely they are going to be compromised, leading to an increased risk of depression or anxiety. Isolation, of course, also is an outcome associated with undernutrition due to both, the low energy and not being able to get out, and also those mood symptoms, making someone really not feel up to going out in the way that they used to. So, of course, some degree of weight loss can be attributed to the normal aging process. So like I said earlier, you do want to always investigate when you see a 5% or more weight loss in someone over 6 months to a year. But in some cases, some weight loss can be normal. Why is this normal? Well, we hear about anorexia of aging. This includes the natural decrease in appetite as we age, decrease in lean body mass, so sarcopenia, you might hear it called as, changes in taste buds. So our taste buds change as we get older, as Laurel talked a bit about, and we're going to need stronger flavors in order to taste food in the same way as we did when we were younger. Digestion, absorption, and metabolism also changes as we age, and physical activity level tends to decrease as we age. So normal sort of standard weight loss in the aging process that we don't worry about tends to be about half a pound or less in a year. So, it can be normal to lose a pound every couple of years, but anything more than that definitely needs some further workup and investigating. So now I want to go through the different possible causes of weight loss among older adults. This is really important because the intervention is going to be different based on the cause. So when you or a loved one or a patient is experiencing weight loss, you always want to look further into it and better understand the etiology. So the first set of possible causes that I'm going to talk about are the physiological causes. So one really common, physiological cause that people tend to think of right off the bat is malignancy. So, a cancer patient, losing their appetite and experiencing weight loss due to the progression of the disease. Any other chronic disease someone is experiencing, we hear about it using the term cachexia. When someone's cachexic, they're losing weight due to their chronic disease. If the weight loss is short term, it could be due to just an acute illness, and it will resolve once the illness has resolved. Someone suffering from dementia or poor cognition, as Laurel said, could contribute to weight loss and undernutrition. Poor dentition, so missing teeth or ill-fitting dentures could contribute to weight loss. As Laurel talked a lot about, difficulty swallowing, what we call dysphagia, can contribute to weight loss. And lastly, medication side effects. So there are lots of great medications out there that actually can decrease someone's appetite. There's great medications out there that can cause dry mouth and therefore cause difficulty swallowing or difficulty chewing. So all of these possible causes need to be investigated. And, someone could have one or multiple of these physiological causes contributing to their weight loss as we age. Next, I'm going to talk about the psychological causes. Now, for me, as a eating disorder, behavioral health dietitian, I am very passionate about sharing these factors that influence weight loss among older adults because of the stigma associated with psychiatric illness. Oftentimes, these factors get overlooked because we're so focused on those physiological and medical factors. Depression is actually one of the most leading causes of weight loss among the older adult population. So compared to younger folks who experience depression, it's actually more likely that an older person with depression is going to lose weight in the context of the illness progression. It's also, with that said, important to note that when someone's not eating well, when someone's losing weight or at too low of a weight from their baseline, medications, especially medications that help treat depression and anxiety and other illnesses, are actually very poorly absorbed. And it makes sense, right? We need nutrition to help our bodies properly metabolize medications. So if we're not getting enough nutrition, medications are not going to work in the way that they're meant to work. And unfortunately, this becomes a vicious cycle because as someone becomes more depressed, they tend to eat less, lose more weight, the medication isn't working, and therefore they continue to feel depressed and lose weight. So it's important to really work closely with a psychiatric provider to help mitigate the poor appetite, to help improve the poor appetite and to help mitigate the weight loss in order to help treat the depression. And as we see the depression lifting, we're going to see the appetite improving, but also as we see the appetite and the eating improve, we're going to see the depression improve on its own. A second possible psychological cause is eating disorders. So we tend to think, when we think of anorexia and other eating disorders, we tend to think of younger people. But there's more and more research and evidence out there that eating disorders affect older adults as well. And this can be either, someone who struggled with an eating disorder their entire life, or someone who has a new onset eating disorder. Again, because we're so bombarded with, the importance of eating a certain way and looking a certain way, when someone's aging and sort of lacking control in a lot of areas of their lives, if they have a genetic predisposition to an eating disorder or disordered eating patterns, this may come about, in a new way in a person who is aging and again has that genetic predisposition for an eating disorder. All of the diets out there telling us to fast or avoid certain food groups, these are also contributing to disordered eating patterns among older adults. And finally, substance abuse can contribute to weight loss among older adults and is more common than people may recognize. Lastly, social causes of weight loss. So someone may lose weight because they're isolated, because of food insecurity, or because of difficulty shopping or preparing meals. So these are also important factors that we want to look into when we're investigating weight loss among an older person. So a multidisciplinary team approach is always so important when we're looking at the weight loss. Specifically, when you are looking to work with a registered dietitian, we have many different areas of expertise. And if you already have the etiology of the weight loss established, it's important to find the right provider. So if you're dealing with weight loss related to depression, you're going to want to find a behavioral health dietitian. If you're dealing with weight loss related to cancer, you're going to want to find an oncology dietitian. Speech language pathologists and occupational therapists are going to be really important when you're dealing with physiological concerns like chewing and swallowing issues. Psychiatrists and psychotherapists are going to be important for mental health related concerns, while physical therapists are going to be important for mobility. And social workers can be really helpful for access to meal assistance programs for those who have difficulty shopping, preparing for meals, or for food insecurity. So now on to the interventions. And these are just a few of the many, many different interventions that someone may put in place to help with weight loss and poor nutrition in an older adult. Because the causes of weight loss are so complex and there can be a combination of many, it's important that each individual gets their own medical advice and intervention. But here are just some of the possible interventions that a provider may suggest. So for physiological causes of weight loss, you're going to want to provide familiar and favorite foods. You're going to want to provide food frequently. You're going to want to provide calorie-dense foods. So foods that don't take up a lot of volume in the stomach, but that provide a lot of calories. So these tend to be the foods that are higher in fat. Providing texture-modified foods if necessary. Assisting with meals if needed. There are also medications out there, such as appetite stimulants or motility agents or anti-nausea medications that can help people who have physiological causes of poor appetite and weight loss. Of course, there's always oral supplements like Ensure and Boost. These are the supplemental drinks someone can drink. And finally, and you're going to hear me say this over and over again, liberalizing dietary restrictions. So not putting any restrictions on an older adult's eating options. Psychological intervention. So of course, you're going to want to get someone who you suspect maybe has depression related or eating disorder related weight loss, a psychological evaluation. Psychotropic medication might be necessary. Again, providing familiar foods, providing oral supplements, and again, liberalizing diet restrictions. Encouraging social eating for the social interventions. Providing access to home delivered or congregate meals, supplemental nutrition assistant programs, providing assistance for grocery shopping, and again, finally, liberalizing dietary restrictions. And depending on what's going on, you might use a number of these interventions to treat the weight loss and undernutrition. So what is my takeaway? So I want everyone to take away that weight loss is really important to recognize because it has a lot of negative health consequences in older adults. It can lead to an increased risk of mortality, regardless of weight, regardless of BMI. Research actually has found that exercise, in addition to eating more, not less, are better defenses against heart disease than exercise and restricting calories. So again, this is very different from the messages we hear. It's also important to understand the etiology, the causes of the weight loss. There is a multidisciplinary team, in order to provide the best intervention. So an intervention for someone who lost weight because of physical reasons may look much different than an intervention for someone who lost weight because of psychological or social reasons. So it's important to really fully understand the causes before we provide the appropriate treatment. And again, liberalizing diet restrictions wherever possible. This is not the time for your loved one, for your patient, for you to be going on a strict diet. We tend to recommend as someone gets older, even if they were following, say, a diabetic diet or a cardiac diet when they were a little bit younger. In most cases, this isn't appropriate when we get older, because we want to make sure they're getting in as much nutrition in whatever form they can, as many calories in whatever form they're willing to eat and able to eat. So, let your loved ones eat the cake if that's what they enjoy, and enjoy, all the different foods, and try to avoid putting any restrictions when someone is getting older, because it can actually unintentionally make things worse rather than better. This is just a list of my references, and I am going to turn it back to Brenda for our Q&A. Thank you so much.
Thank you, Laura and Laurel. For some reason, everyone, I cannot get my camera to work. I don't know why. So there's a couple of things that really stood out for me. The first, Laurel, you had said some stimulation can increase the appetite. And I thought that was an interesting comment. So could taking someone, your loved one, just for a ride, again, it's nice weather now, taking them for a ride around the neighborhood. Is that what you're talking about in reference to some simple stimulation?
Yeah, so sometimes if you go on a nice long walk, that can make you hungry, but for other individuals that may not be accessible. So going and doing something that is emotionally stimulating, that is mentally stimulating as well, can be of assistance. So yes.
Great. And another comment, Laura, you had said this, which I had never heard before, and I think my audience probably would agree. The ideal weight range for longevity for older adults is in the overweight category. That just blew my mind, right?
Yeah.
Yeah. It tends to be shocking to people, because all throughout every life stage, we hear about healthy BMI, the dangers of being overweight, when in fact, in this very specific older adult population, having a little extra weight can actually be protective and actually put someone at decreased risk for some negative health consequences. Again, this is different and only for the older adult population that this is ideal.
I understand. Laurel, you had said, and again, this is something I didn't realize, for someone with dementia, wandering could mean that they're hungry. That was a very interesting comment. Again, for my audience, if you've got loved ones who have some dementia, it may not always mean they're restless. As Laurel said, it could mean that they're hungry. Very interesting.
Yeah, we see a lot with wandering. The wandering is really just a way for individuals to communicate that unmet need. So it could be they're thirsty. It can mean they're trying to find the bathroom. It can mean that they're lonely, overstimulated. Wandering is really just a term meaning getting lost. So we see that there are a lot of different triggers that may trigger wandering, one of which is, I'm really hungry. I want to go find something to eat. And then an individual ends up wandering and could wander outside of a home or wander outside of the room because their goal is that they just want to eat or they want to drink.
Right. So let's open it up now to the audience. Folks, if you've got questions for Laurel or Laura or both, please feel free in the either at the top or the bottom of your screen or the chat box. So I see we have a question. Our first question is, can unintentional weight loss be attributed to a gastrointestinal disease?
Yes, absolutely. So if someone's GI tract isn't working in the way that it should, they may be eating enough food, but they're not absorbing those nutrients. So that can lead to weight loss. So if you suspect that you or a loved one or a patient is experiencing a gastrointestinal disease, it's important to get a full workup, because it may look like they're eating adequately, but they're not actually absorbing all of those nutrients that they're taking in because of the GI issue.
Right, right. We have a question. Can you recommend something besides Ensure that is not thick and milky, but clear for my mom to drink?
So they actually do make something called Ensure Clear, which is a juice type of Ensure. But if Ensure isn't your thing, which is understandable, some people love it, some people hate it. You can be creative. You can make a milkshake that'll do just as good of a job as an Ensure. Things like nut butters, avocado, blending those things up with fruits could create a really tasty, high calorie, healthful supplement for your loved one.
Right. Okay. Let's see. I think we have time for maybe one more question. Can you recommend a supplement or something to boost the appetite?
So there are certain medications that a physician can prescribe that can stimulate appetite. So if this is something that you are curious about, it's something you should contact your physician, primary care provider, gastrointestinal doctor about, and they can give you some options. But there are definitely options out there for appetite stimulation that can be explored.
Okay. And I actually have a question. Laura, you had mentioned in your presentation, not dense foods, but high calorie foods. Can you give us some examples of that?
Sure. So actually foods that are calorically dense are the foods that we want to focus on. So these are foods like nut butters, avocado, nuts, foods that are high in fat, oils, right? Because when someone is having difficulty getting in enough nutrition, they can feel full very quickly. So we want to decrease the amount of space the food takes up in their stomach so they don't feel as full, but pack in as many calories as possible. So, for the general population, you hear about foods that are high in fiber, that are going to sort of fill you up and not provide as many calories. It's actually the opposite for someone who is struggling to eat, someone who is losing weight. You're actually going to want to provide low fiber foods so it doesn't feel as filling, but they're able to take in more calories.
Okay, great. Thank you.
That's so interesting. That's why these presentations are so wonderful, because as much as anyone is here maybe learning from us, this is such a pleasure because I'm learning so much from you, Laura, that I had no idea. So thank you. That's wonderful.
Right. Absolutely. Absolutely. So folks, we're at that time. I want to thank you both, Laura and Laurel, for presenting. And thank you, everyone. Again, I apologize for my video not coming back on, but we want to thank you for joining us tonight. And I want to thank my colleague, Gina Forgione. Gina is in the background and she does work. She's the girl behind the screen, behind the screen. So I want to thank Gina too. And folks, if you'd like to learn more about the Kensington, again, please feel free to go to our website at www.thekensingtonwhiteplains.com. And if you hold on for a minute or two, Gina's going to put up an end slide, and that will include contact information for Laura and Laurel. So hold on for 1 second, and thank you so much. Thank you.
Thank you, everyone.